Sir, I'm happy to present.
Yeah, sure. Okay, all
It's
right.
fine.
Sure. Okay. So what did you see in the video?
In the video, I can see a 3-month-old child. I'm able to comment on the setting. Most likely in hospital setting. No devices I can see in the video. The child's. I'm unable to comment if he is unwell or toxic looking child. I can see a child who is average for his body build, but I would like to plot the height and weight on the appropriate centile charts. I can see there's a visible mass moving in abdomen, moving in different directions, but otherwise it's unable to comment whether the child has jaundice as well or not. But there is a mass which is clearly visible in the video.
Okay. So all right. So what do you think the child is having?
Given the history, my top differentials would be an abdominal mass, likely malignancy. If systemic symptoms are present and poor weight gain along with it, my first differential would be neuroblastoma or Wilms tumor, could also possibility. Any renal anomalies like hydronephrosis or multicystic kidney can also be considered.
This child is okay, 3 months old, and now still the Ikra, you are not supposed to please answer here. I told you guys, okay, no, you are not supposed to do a answer here.
Okay. Okay.
Okay. So sorry guys. Okay. So basically, the thing is that this child is having, 3 months age and having throwing up, like, non-projectile vomiting. So and having this mass. So do you want to keep any other differential diagnosis?
3-month-old with the persistent vomiting. I can also think of pyloric stenosis. However, the age is not characteristic for pyloric stenosis at this. They present usually from till up till 8 weeks of age. But this child is 3 months, but it could be a possibility.
Okay. All right. So do you want to keep any other differential diagnosis? No.
Um,
So
sorry, I can't think of anything else.
okay. All right. So yeah. All right. So what additional history would you like to take in this case?
So I would like to ask about the onset course duration of which we have already some things are mentioned in the STEM, but I would like to know what the vomit contains. It is frequency, amount, projectile, non-projectile, bilious or non-bilious in nature, feeding history, growth history. I would like to also see the vaccination and developmental history, and history of ep- uh, diarrhea, loose stools, or constipation, systemic features like fever, lethargy, and respiratory distress.
Sure. Okay. So what examination would you like to do?
I would like to do first the general examination and whether the signs of dehydration are present. Abdominal history looking for hepatomegaly and tenderness, and detailed neurological examination as well, and any pallor, bruising, or bleeding anywhere.
Why do you want to do detailed neurological examination?
Because I'm keeping malignancy in my differential, so I would like to rule out if there's any painful joints or swelling present in anywhere else in the body.
Okay. All right. How do you manage this child?
So I will involve myself, my consultant, and I would like to plot height and weight on appropriate charts. I would like to also do a blood pressure, and I will do the appropriate investigations, which will be guided by the history and like
What appropriate investigation would you like to do
so.
in case
This
suspected
would help.
hypertrophic hallucinosis?
Yes, baseline bloods, electrolytes, and abdominal ultrasound would be very helpful in this case.
Okay. So electrolytes.
Sorry.
You want to do serum electrolytes?
Yes, I would like to do ABG and electrolytes along with an abdominal ultrasound.
So what abnormality you get in case of serum electrolytes?
So if it's a case of pyloric stenosis, I'm suspecting everything to be low. So it is metabolic alkalosis, hypocholeremic.
Okay. Okay. All right. So how do you further manage this child?
So if the child is dehydrated, we'll start him on 175 mils per kilo of normal saline with dextrose and 10 millimoles of KCl. If the child is not dehydrated, then I'll start on 150 mils per of normal saline, and we'll keep the child nearby mouth, and we'll put an NG for decompression, and replace the gastric losses male to male.
Okay. So what is ultimate treatment available after
So
that?
the definitive treatment is surgery, which is pylorustom. But first, we have to correct the electrolyte imbalances before going to the surgery.
Okay. So are there any complications associated with the surgery? What is the kind of surgery they do? This case?
Sir, I think it was Rumstead. Forgetting the name exactly.
Okay. All right. So what are the expected complications this surgery?
So we might expect vomiting 1 week after the surgery, but otherwise no follow-up is required normally, and the child recovers well.
Okay. All right. Thank you very much. Okay, so your station is over. Let's do the discussion. So yes, Gul, how was it?
Sir, I think I did not pick the right diagnosis because of the age, I confused. Otherwise, I would have put the pyloric stenosis at my top differential, but I think the 3 months sidetracked me. Think I thought about the pyloric stenosis, but then I thought the age is not typical for that, so maybe it's malignancy because it's a bloating and distension of the abdomen. So not sure I was approach was right or not.
Okay, all right, sure. So the first, like initially, then you have to think, so this is a baby boy and firstborn. You can see that in the stem, you understand, no? So this age group is common, no? Okay.
Yeah.
Firstborn baby, male, sex and having, vomiting and abdominal swelling, okay, for last 20 days. So the first thing you have to think is, you know, so infantile hypertrophic pylorostenosis, isn't it? All right. So we'll come to that. Okay. So guys, actually, Ikra, before we start the session, we told all the rules. I think you joined late, and that's why, Jana, you did mistake. Like, you put the diagnosis, you put the findings and the diagnosis in the
Yeah.
chat box. You should not have done that.
Yeah.
All right, when mock is going on. So, all right, guys. So I want to hear from others. So how was Dr. Gul's performance? Now I want to ask, okay, Ikra, you tell us. How was
Hi, sorry about that. I wasn't
No
aware of the
problem.
rules. I'm really sorry.
No problem. No problem. Okay. How was
Uh,
it?
I think Gul did really well in terms of picking up the findings and framing them in the way. It was really good. And Gul has rightly said that I think she has confused it with the age. Otherwise, I feel that the history examination was good.
Okay.
Differentials might have been better, but a nice try.
Sure. You tell us what are the differential diagnoses you would keep, like, when baby comes to you.
I just saw the video, and from the video and from the age, it just clicked me that there are visible peristaltic movements, and then the shape of the mass clicked to me that olive-like mass, the way we used to read in the books that the olive-like mass would be there, and then this visible peristaltic movements, and then the history was really suggestive. So that makes me think the diagnosis should be hypertrophic pyloric stenosis as the first top difference.
Okay.
Considering the other diagnoses, I would have considered intestinal obstruction secondary to other causes, atresias, intestinal atresias, or intestinal um, volvulus or malrotation or something like that. I might have considered one of those diagnoses as second or third, and then down the list we could have considered malignancies as well, but I think they are very rare in this age group. So I would be afraid to keep them in my differential list. Only I would be saying them if examiner is really pushing for more differentials. Otherwise, I think I would avoid.
Better to avoid those things. Okay, I feel.
Yeah.
Okay. Okay. All right. So what about others? Deepti, do you want to say
Um,
something?
Hi, this is Sarika. I would like to
Very good.
keep other differentials as for vomiting basically. So this child might have in GRD. We can keep UTI as one of the differential as the child has vomiting, and maybe your yeah, the ones which they have already said: IHPS, intestinal obstruction, UTI, and GRD. I think these four can be the differentials.
Yeah, very good. All right. Anyone else would like to say something about the management? Hafiz?
About the management, I think the
Hmm.
one what she said was nice, that we need to really first investigate this child. So as this child has come into the emergency, this child will need stabilization. So I would like to first see that the child is hydrated well. I would like to see the saturation. I would like to see the blood pressure of this child. After examination, I would like first to put the nasogastric tube with open end, to give the stomach rest with the IV fluids. As she said that if the baby is dehydrated, then we'll give the dehydration fluids. If the baby is not dehydrated, then we'll give the other like 150 ml per kg. The in the investigations, what is important is the ABG is important here, because it will show hypochloremic, hypokalemic, metabolic alkalosis, and that needs to be corrected. So along with that, we will send the electrolytes, because only after the potassium we will be able to add the potassium into it. And after the initial stabilization, then we'll give a call to the surgeons for the definitive management as Ramsted's pyloromyotomy.
Anyway, surgeon has to be kept in the loop. Okay. So
Yeah.
initial management is a medical, I agree. It's not a
Yeah,
surgical.
sorry. The first thing is consultant admission, and then surgeon in the loop, and then managing this baby that way.
Yeah, because the definitive treatment is Ramsay pyloromyotomy anyway, later.
Yes.
Yeah, I agree with you. Okay, all right, guys. Okay, thanks for the input, Sarika. Okay, Vidya, Anu, anyone else? Okay, all right. So thanks for the participation, Dr. Gul. Um, yeah. So yeah, you were trying to do the station, but yeah, the diagnosis, the differential diagnosis were going wrong. But Ikra tried to help you. Yeah. Okay. So after that, you try to
Sir,
pick up.
I didn't read any messages. I'm reading now, but I didn't.
Okay. Okay.
I
In
was not
that
aware
case,
somebody was writing in
okay.
the notes. Yeah, yeah.
Okay. If that is the case, then I'm happy. Okay. So then at least later you try to tell the okay infantile hypertrophic hallucinations. I'm happy for that. Okay. Okay. So this child, 3-month-old infant, having the vomiting and abdomen tummy swelling for last 20 to 20 days to 30 days, and not gaining weight. Weight is just 3 kg, 3 months old, first born baby. So typically, you see that in this video, there is a olive-shaped swelling which is moving in. So from left side, this left hypochondrium, and towards the right side is moving every time. All right. So the first differential diagnosis, putting all this together, you have to think of infantile hypertrophic pallosions, definitely. Okay. Then after that, other differential diagnosis, you can say, yeah, I agree with others. Okay, it could be just acute gastritis, it could be GRD. I agree with that. Okay, UTI possibility is there, provided the swelling is not there. Okay, and yeah, then other gastric outlet obstruction syndrome. Okay, so maybe gastric, the web in the web, or like something in the pylorus. Okay, sometimes yeah, volvulus and intestinal obstruction possibilities. That yeah, I agree with those differential diagnosis.
Can
Okay.
we keep RT as one of the differential diagnosis here at this age?
Yes, possibility is there, but you have to keep it lower down, very much lower down.
Okay.
Yeah. Okay. But only thing is that, yeah, so provided that abdomen swelling is not there, so like, like GERD or something like that. Okay, in that case, UTI or acute gastritis, you don't get
CH, CH.
possibility is there. Yes, possibility is there. Yeah, possibility is there. But once you know that investigations like child is having
Yeah, yeah,
hypochloremic,
yeah.
hypokalemic metabolic alkalosis, then your differential diagnosis is also very deep. Based on this finding, what are the diseases you think then, Sarika, in that case? Where
Sorry.
else you get metabolic alkalosis with failure to thrive with
Yeah, we will get in acute gastroenteritis or here like this in IHPS and RTA. RTA will also have hypochloremic, hypokalemic. No,
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 in
no.
RT
Alkalos.
there is
No, it is
acidosis.
acidosis. Sorry, sorry, sorry.
Also,
It is
we
acidosis.
also we think for
We
Bartter
can say
syndrome
Barter,
and
cystic fibrosis.
CH, cystic fibrosis,
very good, fantastic.
and
Okay, I'm happy.
tryptophan.
Yeah. Renal tubular acidosis, okay, as name suggests, it is acidosis. You'll get metabolic acidosis, okay. Normal LAN and gap metabolic acidosis you'll get in RTA, okay. So if metabolic alkalosis, hypochloremic metabolic alkalosis picture is the first thing you have to think is about infantile hypertrophic hallucinosis. Then congenital, chloride diarrhea. Okay, so giving loop diuretics can lead to picture like this. Okay, then we can also get in case of cystic fibrosis. I agree. Okay, so that's called pseudo Bartter syndrome, and and Bartter syndrome definitely. So DDs might vary based on the clinical presentation, based on the investigations once they are available. Okay, so there are many DDs actually can keep in this baby. All right. So how do you, yeah, the next question was, what history would you like to take?
Just one question, please. I did this
Yeah.
video some time back, and I commented like on olive shaped mass, but I got a very harsh comment in it that you don't have to comment on olive shaped mass because you can't see it in a video. They said that you have to feel for it. You can just say that you can see a visible peristalsis, but don't say olive shaped mass because that can only be felt. How can you just by seeing the video say that there's an olive shaped mass? So what you would say about this?
You can say I can see a round oval shape, swelling, something you can describe, whatever, like, whatever is there. However, I would like to confirm it further by
Okay.
examination.
Okay.
Okay, it's not hard and fast, like, so you can try to avoid that olive shape, no problem. No problem. Okay. All right. So, yeah, what additional history would you like to take? Onset, course, progression. Okay. The, feeding history in detail, like, whether baby is vomiting after feed, before feed, and what is the relation with the feeding? That's very, very important. Usually in case of hypertrophic hallucinosis, typically after feeding 5 to 10 minutes, they will try to vomit. Okay. Usually non-bilious, non-projectile. Sorry, projectile, okay, non-bilious, okay. So that kind of vomiting you'll get, okay. In case of yeah, so same GERD also you will get the same thing, but only thing is that gastroesophageal reflex. So it's not kind of like projectile thing, but non-bilious thing. The vomiting can be there even after feeds. Okay, so
Changes
then
with the position. If at all
change
propped
in
up
position.
position, it reduces.
Yeah, sometimes making neck like this, okay, it's kind of thing, so milk coming from the nose, everywhere, and child, if the child is having failure to thrive, so so that's also important. Okay, initially you may not get the thing, but later you will get failure to thrive in case of infantile hypertrophic hallucinosis if the case is missed for a long time. So in case of GERD, usually they are healthy babies and you don't get, failure to thrive in the case. Yeah. So other differential diagnosis, so UTI or gastritis or something else in other cases. So you won't get, failure to thrive and those things. So if you're suspecting Bartter and other, yeah, definitely the failure to thrive, polyuria, those things will be there. So onset, course, progression, history of feeding, vomiting, relation, okay, what motion, abdomen swelling, those things, and detailed birth history and family history. Yeah. So that's it. You have to tell about the question. Then what examination would you like to do? So general, I agree. Okay. So if the child is sick, I would like to go ahead with the primary assessment, second assessment. You can say if the child is not sick, you can say, yeah, so the normal examination. So I want to look for the dehydration, so that's very good. Like I would like to check the pulse, capillary fill time, pulses. I would like to palpate pulses. Very good. I'm happy about that. Okay. And also do the abdomen examination. You told neurological examination. I wasn't happy about it. Okay. So why did you tell that, Dr. Gold? neurological examination you told?
So because I kept malignancy in my DDs, that's why. Otherwise, if I was, sir, the problem was I was not sure from the very beginning the diagnosis. If I was clear that it is pyloric stenosis, I would have just focused on more gastrointestinal part. But because I was sidetracked from the, this happens when from you don't pick the station good from the beginning, then you just lose it, and I think that's what happened.
Yeah, I
Then
agree.
because I was preventing my differentials because I'm keeping malignancy in my differential, so I had to mention something that why I'm doing what I'm doing. So that when where I lost, I think.
Sure. Usually, I tell you, neuroblastoma or Wills tumor, okay, they won't come for the video station, okay? So they are meant for the short clinical stations,
Oh,
okay?
sure, yeah, that's fine. Sir, I think like I told you, the 3 months thing. I said it's very late for a pyloric stenosis to develop, so that's why
Oh, it is late.
yeah.
It is common somewhere between 2 to 4 months. It's common, no? That's this is
So maybe I'm wrong, but I thought after 8 weeks it's not that common.
2 to 4 months. It's common. What do you guys say? Others,
Yeah.
okay. So 2 to 4 months is the
Yeah,
usual
yeah,
time, no? Sarika,
yeah,
what
yeah.
do you say?
Yeah,
3 months
yeah.
is
And
okay.
actually
3 months is
the
okay.
complaint started since last 1 month. So
Yeah,
maybe
see
this
Yeah.
that.
you might just have thought about 3 months, but I think you should minus 1 month so that 2 months. So basically
Yes,
the complaint started from 2 months.
yes.
Okay,
See that.
okay, okay, okay.
In that case, okay. So presentation. So it is not always like that. Okay. So sometimes they might, it might start maybe as early as 6 weeks also. It's
Mm-hmm.
might go up to even 4 months, 5 months also. If it is missed, they will have just like, very thin child, like look like, skeleton
Mm.
later, like, if it is missed for a long time.
Okay, okay, sure.
So then, yeah, so I would like to, you can say that I would like to palpate the fontanelle and those things. Okay, you can say, okay, if required other system examination, I would like to do. You can say that, no problem. Okay. And after that, yeah, so this case, I will inform my consultant, I will admit this child. Okay, I would like to run the investigations. Okay. So for the pyloric stenosis, I would like to do. You can say full blood count, okay, that is okay. Serum electros you have to say, blood gas you have to say, okay. So venous blood gas you have to do because you want to know the acid base status there. Yeah, so that's very important, okay. And renal function test you have to do, okay. So why do you want to do these things? Okay, then you would say what I'm expecting hypochloremic, hypokalemic metabolic alkalosis. Okay, so that is why I would like to do RFT is because of the dehydration. Child might get prerenal the prerenal changes, prerenal failure changes like urea might get elevated as compared to creatinine and those things you can say. Okay, why I see a full blood count? Okay, because I would expect hemoconcentration, okay, rise in hematocrit and those things you can say are, if I'm suspecting sepsis also one of the DD here, like you can keep like, in that case, I would expect like, other high or low WBC count, you can say. All right. Then, yeah, definitely I would like to.
Ultrasound after the consultant.
Yes,
UAG.
yes, yes. Ultrasound abdomen. Okay, so what do you expect? What do you get in ultrasound, guys?
4 millimeter and 17 millimeters. The pylorus.
Okay, which one is
Or
4? Which one is 17? Tell me.
the length is 17 and the breadth is I think 4.
Yeah. Okay, so pylorus will be like, the circular muscles will be hypertrophic. So just remember like more than 14 by 4, just remember 14 by 4. 14 millimeter that length and width is more than 4 millimeter. Okay, all right. And further, how do you manage? So first of all, if the child is dehydrated, okay, so or the child is having signs of hypovolemia, shock, okay, I would like to give isotonic crystalloid. Okay, that is 0.9% saline, 10 ml, 10 to 20 ml per kg bolus. And after that, fluid calculation is initially like, you can say 150 ml per kg. Okay, you have to give 5%, that's also 0.9% normal saline. You can add potassium 10 milligrams in 500 ml, that's okay. So where is that 175 ml per kg given?
I
Sherish,
think it is in the guideline
There new
if the
guidelines have
baby is
changed.
dehydrated. If the baby is dehydrated, then we give 175. If the baby is not dehydrated, we continue with the 150 ml per kg.
These are new
It
guidelines, so
was
I have
150 or
just
120?
No,
no,
150
no,
I
no,
have
no.
seen, okay, but 175 I didn't say. Actually, I need to check it. Okay.
Sir,
No, in the
these are new
metabolic
guidelines.
calculus 150 and no metabolic calculus 120 is there.
120, yeah, I have also read this 150 and 120.
I can share in in the Zoom meeting. These are new guidelines, just released just a few months back. So it's 175 now. If they're dehydrated or not dehydrated, is 150. So these are the latest
Okay.
guidelines.
Okay, in the
Okay.
new
Okay,
guideline
we
it
go
is
through
changed.
that.
Okay. I didn't go through that.
Okay, just a minute. Okay, now let us try to, confirm now only. Wait.
It's 150 ml and replace the losses.
Yeah, every fourth, you have to insert NGT every fourth hour, you can replace that. I have seen.
150 ml and replace the losses. Yeah.
Okay, but I
And if
175.
you want, I can share here in the meeting.
No, I'm sharing here now. Wait.
Okay.
No, only I'm sharing. Wait. So this is a new guideline. Are you able to see?
Yes.
Okay. All right. So fluid management, keep the child nil by mouth, insert NGT, put it for the free drainage. Okay. Monitor gastric aspirate volumes. Okay. Every 4 hours, replace with the normal saline and potassium 10 MEQ per 500 ml for next 4 hours. Commence maintenance eye fluids. Volume is 150 ml per kg with the highest weight. Choice of the fluid will be 0.9% with 5% glucose and potassium 10 MEQ in 500 ml. Okay, and monitor more potassium may be required depending upon the serum potassium level. Check urea, electrolytes, blood gas, chloride levels every 6 to 8 hourly. So where is 175 ml?
Sir, the guidelines in front of me are from Leicester Children's Hospital, and these are different. Like
Okay,
here it's
maybe I don't know. Okay, but this is a this is the latest guideline. Okay, so they have updated the management of the pyloric. Whatever blue they are given, no. So this is a
yeah. I
new
can see
thing.
that. Yeah.
Yeah.
I can see that. But say here it's written one, so I'm not sure. Like, I know what you're telling me. It's the new pediatric guidelines, but this one is recently shared in the like one in group it's
That's okay.
friends group.
Sure,
So
sure. Just put it in the group whenever you get the time. Okay, no problem.
yeah, no problem.
But
Thank
I
you.
think we have to follow our this guideline, right? Sir, I
Yeah.
think in the video especially we have to follow these guidelines.
Pediatric guideline is very, very important, guys. From first
Yeah.
phase till last phase, you have to read at least 2 times you have to read before you go for the exams, okay? And the neonatal guidelines, you have to read certain topics like, so 6 to 7 topics are there, just you go through them and that's it.
Sir, how to retain these? Actually, I have read these guidelines since FOP, I think 20 or 25 times, but still.
Yeah, I understand. Okay, so the thing is that, see, you need to maybe, so I don't know, okay, if it is okay for you guys, you just try to follow these protocols in your unit, guys. That is how you can remember. That's the
Yeah,
best way
but
of learning.
actually we are living in Pakistan and it is very
Yeah, I
difficult
know,
to
I know.
follow these guidelines in Pakistan.
I know. Locally, you have like local guidelines will be there. So, but for the time being, to clear the exam, you have to tell the answer from these guidelines only, please.
Okay, sir.
Maybe later you can follow whatever so guidelines you want to practice, no problem. But for the clearing exam, you need to just tell the answers given, like whatever the answer management is given in the guidelines. Okay. So yeah, all right. And so this is about the fluid management. I agree. After that, later the surgery is a choice, and so Ramsted pyloromyotomy is a surgical the procedure done. And post-operative complications, sometimes OMT might continue for initial 24-48 hours, so not after, usually after 7 days. Okay, so sometimes stenosis can happen. Okay, so very rare recurrence is rare, but actually I think it's less than 1%, guys. Okay, but it can happen. Okay, so yeah, that's all about the first studio station today. So thanks for the participation once again, Dr. Gul.